go ahead and get started. Make sure I'm doing this right. There we go. So first of all, I'm just going to talk about why study cancer outcomes in adolescent and young adults, which we define as 15 to 39-year-olds. Just really briefly talking about social determinants of health, how we define it, how we look at it, probably imperfectly in some of the research that I do, which is really primarily population-based research. And then my focus on cancer outcomes. So really looking at the time of diagnosis, treatment, and then cancer survivorship, and how we've seen differences across social determinant measures in this young population, and then end with what can we do about it? How am I thinking about next steps? We would never want to just highlight disparities without thinking about how can we mitigate them. So just starting off, why am I focusing on this population? Maybe I'm preaching to the choir here, but cancer incidence is increasing in this young age group. In 2020, nearly 90,000 adolescent and young adults, 15 to 39 years of age, are diagnosed with cancer each year. This is actually a pretty survivable time frame for cancer, which means that we have a really growing population of cancer survivors in this young age group with really a long life expectancy ahead of them. But what you can see here is that cancer is increasing in all age groups, and it does, unfortunately, is the leading cause of death after unintentional injury, homicide, and suicide. So a kind of increasing problem in the United States. And so why do we care about this young population in particular? It's because cancer is pretty different from pediatric cancer and older adult cancers. And that's really where the primary attention historically has been given, to children with cancer or older adults with cancer. But what we find in this age group is this transition from pediatric like cancers, including sarcomas and leukemias, to more adult cancers, including testicular and melanoma in 20s, and then female breast and melanoma in the 30-year-old age range. And thyroid cancer is a really common cancer as well in this age group. And some of my work has been looking specifically at survival. This was really the impetus for focusing on this population. It was highlighted, gosh, maybe 20 years ago now, that adolescent and young adults had worse improvements in cancer survival compared to younger and older cancer populations. So really wanting to understand and look at that and try to improve in that age group. So it was identified at that time that historically this population had been understudied, and it was a really critical time in these patients' lives because of the timing of diagnosis. It really impacts uniquely their sort of development and life. It's when they're establishing their education, families, work, and other relationships. So it's a really critical time period for sort of other reasons, and to get a cancer diagnosis on top of that is incredibly impactful. So this is some work that I published recently, where we were trying to highlight where some of the gaps are in this young population. So there are cancers where we're seeing a lack of survival improvement over time. I'll highlight cervical as one of them. Less survival improvement than older adults for a number of cancers, including stomach and kidney. There are cancers for which this young population has worse survival than older adults, and breast is a really notable one for that. And then worse survival than children. And this is for leukemia in particular, as well as a few other cancers, notably colon cancer, which is increasing in this population. So we have a lot of work to do, and this is really kind of highlighting the importance of focusing on this age group. So kind of with that, we also know there's some challenges in this population, and adolescent and young adults in the United States are the most frequently uninsured. This has gotten better over time due to the Affordable Care Act, but historically, in 2008, nearly 1/3 of 19 to 29-year-olds were uninsured. So in 2022, this is really improved, but still it's the most highly uninsured age group that falls in this AYA age range. And I think you can imagine why that matters. Healthcare, getting an early cancer diagnosis is really important. We also know the impact of cancer, I sort of alluded to this, is really unique in this age group. It negatively impacts, I would say, across all ages, financial situation, but uniquely in this age group, plans for education, work, plans for having children, as well as body appearance, sexuality, and a sense of control over life, with more than half reporting problems upon returning to work. So I will kind of come back to why we think we're seeing worse outcomes in this population, but I wanted to take just a second to define some of the social determinants and some of the data sources that you'll see in this presentation. So this is the definition from the World Health Organization of social determinants of health. It really has a lot of different components, but it encompasses the conditions in which people are born, live, work, and age. And these circumstances are shaped by the distribution of money, power, and resources kind of at the geographic level. And they really are responsible for many health inequities that we see. So to be a little more specific on which each one of these measures sort of relate to and how we try to capture at least a little bit of each of these in the work that we're doing, you can see that neighborhood and built environment really is the access to foods or in your sort of neighborhood environment, quality food, your environmental, the crime in your neighborhood. It's the economic stability, including employment or food insecurity or housing instability in your neighborhood, the availability of quality education. This area has a huge amount of quality education nearby. Not all neighborhoods do. Your ability to access healthcare, so including primary care and specialty care. And then the last one is just the social context of your community in terms of civic participation, the amount of discrimination or incarceration, and just the general social cohesion. So how do we think about how social determinants impact health? And I really like this model. And it's really these upstream inequities that happen, the social and institutional inequities that really can impact living conditions, that can influence behaviors and ultimately health outcomes. So it's a lot to think about, but these are really multifaceted. And we try to now understand how all of these factors do impact health outcomes at the end. So what are some of the data sources I use in California for studying cancer outcomes? So the first is the AYA HOPE study. This was a study out of across 7 cancer registries in the United States. So if you're all not familiar with cancer registries, cancer is a reportable condition nationwide. And so in California, I use that cancer registry. I mean, I would say 90% of my research touches that cancer registry in some way, either interviewing patients with cancer, which this AYA HOPE did to get a patient experience, or just using that existing data and linking it to here. We have a statewide Department of Healthcare Access and Information. So we have statewide data on emergency department visits, inpatient hospitalizations, and ambulatory surgery data. And this is for our 40 million base population in California. So it's a really large, robust data set, and it allows us to really see what's happening at a population level and really see the disparities front hand that I'll be showing you today. The other thing that we look at is our statewide Medi-Cal data, which is Medicaid data, but in California, and we've been able to link that to our cancer registry as well. And then just taking advantage of national data sources, including the medical expenditure panel survey, but there are a lot of national resources that have really shed important light into cancer in this young population. I'm happy to come back to this and the kind of data sources. This is always the challenge, is having good data to look at and to try to answer these questions and move the needle forward. So in terms of our population-based data using our California Cancer Registry linked to healthcare utilization data, we can't do all of what I showed you in terms of measuring all the details of social determinants of health, but what can we measure? So we can look at measures of race and ethnicity, of course, look at some clinical factors, cancer type, stage at diagnosis and treatment, all really important. And then health insurance at diagnosis or initial treatment. That is a big issue, as you will see as I move forward. And then we have a really nice measure of neighborhood socioeconomic status. This is at the block group level, so it's really specific. I think it captures a lot of the social determinants, and I'll show you how what's that's comprised of. In terms of outcomes, with the cancer registry being linked to vital statistics data, we're able to really look at good hard endpoints like survival or mortality, but my interest is really some of those other outcomes like chronic medical conditions or late effects that occur in cancer survivors. And we're able to get that from our statewide healthcare utilization data, as well as some other sources. This is our neighborhood socioeconomic status. So it sort of gets at these living conditions and some social inequities, tying back to the social determinants of health that gets at census block group measures of education, poverty, income, unemployment, and housing. And it's something that was developed in California, but it is now available SEER-wide in the cancer registry. So if you utilize cancer registry data at all, you'll see this measure, and it's really been associated with both cancer incidence and outcomes, as you'll see today. And then race and ethnicity, this is captured either through self-report, medical record, or hospital staff. I have shown you the categories here. They are imperfect. I've included some definitions just to kind of put us all on the same page, most namely that it's a social construct and that's the framework that I come at when I'm looking at this data. But race is considered the identification with a group or identity ascribed by common descent, origin, or physical characteristics. And ethnicity really captures common values and behaviors of people who are linked by shared culture and language. So that's sort of the framework as we see the data today of how I think about it and kind of next steps for research in this area. Okay, so I'll jump in now to some of the data. And so I think in terms of kind of setting the stage of why these social determinants are important, I'm going back a few years to a publication from 2017, and this is with Dr. Parsons, who you'll see we collaborate quite a lot on studies, but this one was looking at the joint relationship of race and ethnicity, the neighborhood SES, and health insurance in California across common cancers in this young adult population. And we found that having public or Medicaid health insurance or no health insurance was associated with worse survival for 11 out of the 12 cancers, right? And that should be horrifying to all of you. Why should your health insurance dictate how well you do after cancer, right? But even with private health insurance, we identified racial and ethnic and neighborhood socioeconomic disparities. So the answer is not just health insurance here. It's more complicated than that. And you can see it here that we found that non-Hispanic Blacks had a greater risk of death regardless of health insurance status, but that Hispanics and Asian Pacific Islanders had a greater risk of death. And that was more apparent for those with private insurance. So even with private insurance, we're seeing disparities by race and ethnicity. And the same is true for socioeconomic disparities. So we found more pronounced disparities in neighborhood by neighborhood socioeconomic status among those with private insurance. So this does indicate that there's some financial burdens even associated with private health insurance. So the answer is not just insurance on its own. It's more complicated than that. But this was really insightful to kind of see how these factors interact with one another. So why might we be seeing these kind of adverse outcomes in this young population? So we are concerned about delays in diagnosis. There is a low suspicion of cancer overall in young people, a lack in many cases of a regular healthcare provider. And this is just due to this population being either highly uninsured, I showed that data, or just not accessing healthcare regularly. And then there's just this attitude of invincibility in this young, age group, like, oh, the symptom will go away. This is not really anything, right? I'm, maybe not as vigilant of getting in as soon. And then I did mention the lack of medical insurance, which really can lead to poor access to care for both that initial diagnosis, but also follow-up care. Something that you're going to hear now is the location of care, that it does matter where you go to get your cancer care. And I'll show some data on what happens if you go to a specialized cancer center versus not in terms of outcomes. But I think unique to this population is how they're treated. Do they go on the pediatric side? Do they go to the adult side? So, and it probably very much depends on the cancer and their age. But they're very different treatment approaches in many cases. And then do they go to a facility where they have access to clinical trials and supportive care, which often happen at a specialized cancer center, such as here. And then really the last sort of concept is a kind of a lack of communication with treatment providers after treatment is completed. They want to move on with their lives. They often move, but what I will show you is there's often late effects associated with cancer treatment. So it's really important to stay connected. And how do we do that and keep this young population connected and getting the care they need through survivorship? So I'll focus. You'll see here sort of the cancer control continuum, kind of what happens from diagnosis, treatment, what causes cancer, preventing, screening. I'm kind of focusing on one side here, which is really once a young person is diagnosed with cancer, looking at stage at diagnosis, and then some treatment related factors, as well as survivorship. So I'll go through each one of these. So starting with stage at diagnosis, how do some of these social determinants that I just showed you impact stage at diagnosis? So again, with Dr. Parsons, we looked at the impact of health insurance by linking our Medicaid enrollment data in California to our cancer registry. And it was important to do this because in California at the time, and the study was all before the Affordable Care Act, if a young person was diagnosed with cancer, they could get emergency Medicaid insurance. And what's captured in the cancer registry would show them as publicly insured when in fact they came in not having insurance. And we wanted to understand, is it public insurance or is it just because they got public insurance after the cancer diagnosis? What is contributing to some of our findings? So from 2005 to 2014, we looked at 9 cancers, which had we could consider stage. You could see it was a really large population, over 53,000 young people diagnosed with cancer. What I have highlighted here is those who had either Medicaid at diagnosis, discontinuous Medicaid leading up to it, or no insurance. So first of all, most people were privately insured in this young age group. But the other really striking finding was that this continuous Medicaid meant they had Medicaid leading up to cancer diagnosis. So only half of our population actually had Medicaid insurance prior to cancer diagnosis. So when we were interpreting and trying to understand our findings, we realized that those we were saying had public health insurance, really they were uninsured or did not have insurance before that. And that was something that happened after cancer diagnosis. And I think that's really important to keep in mind when you're looking at this data, is when they're getting it, and maybe it's just a short period and then they lose their insurance after treatment. And really a small proportion had continued to have no insurance after cancer diagnosis. So what does this mean for outcomes? So compared to those with private insurance, we saw that all young people with public insurance had worse survival, but it was better if they had continuous health insurance, but still still not what you want to see, but particularly Medicaid diagnosis was associated with a 2.5 times higher risk of late stage disease. So this one focuses, I'm sorry, on stage, I said survival, but this is focusing on a later stage diagnosis. So compared to public insurance, private insurance, continuous Medicaid had about a 50% higher likelihood of late stage disease, about a twofold if they had discontinuous or they were on and off Medicaid, and 2.5 times more likely to be diagnosed with late stage disease if they had Medicaid at diagnosis. So really pointing to the importance of having insurance leading up to that cancer diagnosis. We also found differences by race ethnicity with stage at diagnosis. So we found that non-Hispanic Blacks and Hispanics, even after controlling for health insurance, were more likely to be diagnosed with a later stage disease, and the same associations by neighborhood SES. That is, those in the middle or the lowest SES neighborhoods were more likely to be diagnosed with late stage disease. So since I started out talking about survival, this is really stage. We're starting to put the pieces together. We know that being diagnosed as early as possible is really important for outcomes. And so this data is starting to show that from the very beginning, these social determinants are impacting when somebody is getting diagnosed and really associated with later stage disease, which sets them up for poorer outcomes. So our findings do suggest that access to continuous healthcare or medical insurance allows for regular contact with the healthcare system and is important for decreasing the likelihood of late stage diagnosis. But even with continuous insurance, we saw here that AYAs with Medicaid still had a higher likelihood of later stage disease. So this highlights that there's still challenges with access to care in this population. So I'm going to move on now to cancer treatment. And what we do know about this young population is they have a lower participation in clinical trials. In pediatric or childhood cancer, so typically 19 years of age and younger, the majority of children are treated at institutions that participate in NCI-sponsored clinical trials. So you get a really high enrollment, as many as 2/3 in clinical trials. And this has really improved survival in this population. But older adolescent and young adults are more likely to be treated in other settings, in community settings and adult settings with lower rates of clinical trials. So in 2006, we identified that 14% were enrolled. So that's a big gap, right, from children. It's a big drop off in clinical trials, which means that we don't have the same advances in how to treat this population as we do in children. So we do know, and some of this is changing, fortunately, that your health insurance does impact often whether or not you can participate in a clinical trial. So in 2006, so a number of years ago now, we found that those who were uninsured were less likely to enroll in a clinical trial. But we unfortunately, over the next few years, saw that this improved over time, that insurance wasn't as much of a barrier. So, and I think that is continued now moving forward. But we do find, we have historically found differences by insurance. We've also found differences by race and ethnicity, with AYAs of non-Hispanic Black, race ethnicity less likely to enroll than non-Hispanic whites, and non-Hispanic whites continue to make up the largest majority of participants. So I think it's a goal of many of our centers to really increase the diversity in clinical trials. But again, we're seeing a pattern here of who is getting into these studies and having the opportunity to have the state-of-the-art care that you get in a clinical trial. We were fortunate in the AYA HOPE study to do a little more deeper dive into cancer treatment and try to understand appropriate cancer or guideline treatment for cancer. In this study, we found that 68% received appropriate treatment. Of course, we want that higher. It's pretty good, but we really want it higher in general. Again, this was a population-based study. So, you see a variety of diverse populations, which is great, but we 68% is not the ideal, right? This did vary by cancer type in terms of who the proportion that received treatment. But there are two pieces that are notable here: that enrollment on clinical trials, you were much more likely to get appropriate treatment if you enrolled on a clinical trial and if you were treated at an NCI designated cancer center. So remember that piece, because those are two important pieces here. So who's getting into trials, right, to get appropriate treatment? And then I'll talk more about what does it mean to get treatment at an NCI or a specialized cancer center, and how does that associate it with outcomes? So those are two important pieces that I'll come back to later on. And in this study, we found that Hispanics and non-Hispanics, Blacks, were more likely to receive appropriate initial treatment, which was great. I'm going to breeze through this, but some recent work that we've been doing in California have been looking at cancer quality measures. So understanding in more current data whether we see differences in meeting quality cancer metrics by health insurance. So this is data from 2014 to 2021, so more recent data. And I won't get into the specifics here, but what we see is that AYAs with Medicaid kind of consistently were less likely to meet the quality metrics that we looked at in this analysis. So these were for breast cancer, chemotherapy, and radiation administration, and this is all compared to private insurance. We also looked at colon cancer, and the same sort of pattern emerged. Now, it's not across the board, it's not all quality measures, but it is pointing to some concerns that your insurance will impact the quality of care that you get. And I mentioned location of care. This is a really important area of research for Helen and I, but as well as some other colleagues of ours, because what we found is that care at a specialized cancer center is associated with superior survival. Now, this is specifically for acute lymphoblastic leukemia, but again, it highlights something we don't want to see, right? Where that is where you go and get your care will dictate your outcomes. We think it's for a number of reasons that you may be more likely to get into a clinical trial, get appropriate care, have the supportive care services, hopefully come back for survivorship care after your cancer diagnosis. So we want to understand this more and figure out how we can improve outcomes for everyone, and not just those who are fortunate to get their care at centers like here or like UC Davis. So this was a study here where we looked across three different states, and we see differences by state. We had done a lot of work previously just in California, really wanted to understand more broadly what was happening, and we're able to work with the cancer registries and collaborators in each one of these states to understand care in this population. So overall, 18 to 49% of AYAs with acute lymphoblastic leukemia received care at specialized cancer centers, and it increased over time in California and New York, but not in Texas. And what are some barriers to care? Unfortunately, these social determinants are coming back in again, which is why I was highlighting it before. So if you're uninsured, that's a barrier to get to these kind of facilities. If you're publicly insured, particularly in New York and Texas, we don't see that in California. Unfortunately, your race and ethnicity, if you're a Black or Hispanic race and ethnicity in California, you're less likely to get care at these facilities. And if you're living in a lower SES or socioeconomic status neighborhood. So I'm not painting a great picture in terms of the social determinants here, but we're sort of seeing a pattern, right? Later stage of diagnosis, it's impacting the initial treatment you're receiving, where you're getting your care. So how does this now relate to survivorship? So kind of moving along this cancer trajectory. The first thing is health-related quality of life. So we were able to survey adolescent and young adults and understand what was happening. And this is where we found out about how it impacted their life in terms of work and education. But we also found out that cancer, not surprisingly, is disruptive to daily activities, and functioning, and in this case, among more newly diagnosed adolescent and young adults. So they did have major decrements in physical and psychosocial health-related quality of life, but we wanted to understand how that differed for populations of these survivors. And we found that health-related quality of life was worse for those who of Hispanic ethnicity, with lower education, and the stress of lacking insurance, again, at any time since diagnosis. So again, pulling in some of those social determinants are really impacting the well-being of this young population. I also wanted to share some newer work in our VOICE study, which utilizes data in California. For this in particular, we've partnered with a really large health system, and the study utilizes both our statewide data linked to healthcare utilization, but also within this health maintenance organization. And what's notable about this one, not only the size of it in California, is that they accept all types of insurance. So what we're finding is, even though everybody in this large health system has insurance, they have all types of insurance. They have high deductible plans. They come in through our Medicaid or Medi-Cal program. So it's helping us understand that even with insurance, the kind of barriers that are there. And so in this study, we wanted to understand this sort of 2 to 5 years. What we want to see is that our young cancer survivors are coming in for routine care. They're not going to the emergency department because they're feeling good enough, but they're coming in for oncology care, for primary care, and starting to get the surveillance that they need as cancer survivors. So this was sort of preliminary work out of our Southern California group. And what we found is about 38% had at least one emergency department visit during this 2 to 5 years. They are primarily out of cancer treatment, so they're coming in for other reasons. 25% had no oncology visits in year 2, which is pretty soon after cancer diagnosis, rising to 38% in year 5. And 32% had no primary care visits in year 2, and this persisted over time. So not exactly the patterns we want to see in an insured population. So definitely work to do on that front. But then we wanted to understand as well is who are some of our higher risk groups. And again, we're seeing this pattern here of ED utilization being more likely among certain populations, in this case, adolescent and young adult cancer survivors of non-Hispanic, Black race and ethnicity, and those with public insurance within this health system. We also wanted to understand who didn't have any oncology visits during our follow-up period, and found again that this differed by race, ethnicity, with Black, non-Hispanic Blacks, as well as those with public or high deductible insurance being more likely in any year not to go and see their oncologist. So these are real barriers in this population. And why does this matter? Overall, why do you need to come back and see your primary care or your oncologist? And it's because due to the cancer itself or the cancer treatment, this young population is at an elevated risk of medical conditions and late effects. So AYA cancer survivors, they really have a lifelong elevated risk of a number of conditions, including cardiovascular disease, and I'll share more of those in just a moment, as well as second cancer. So this was a really great study out of Southern California. We are redoing this work right now, incorporating Northern California, seeing very, very similar things, very sharp differences compared to a matched population. But the prevalence of multiple comorbidities approached 40% at 12 years after diagnosis, so, and nearly twice as much. So this really points to the need for this lifelong care. I probably should have showed this before the healthcare utilization, but this is why it's important for this young population to continue to get the survivorship care that they need. And a real focus of my work is to understand these disparities and these I'm going to call them late effects here. They can also be called chronic medical conditions, but it's in these young cancer survivors. And are we seeing differences by these social determinants of health? And we really are. So just like from the very beginning, when we saw survival differences, this is now sort of helping us to understand why we're seeing differences by health insurance, sort of along the trajectory, including for late effects. So I have this figure here of cardiovascular disease, and you see a striking difference in the incidence. So much higher incidence of cardiovascular disease if you have public or no insurance. And then I've shown here where we've seen this across a variety of cancers. So most late effects, not just cardiovascular disease, a number of them are higher of survivors of Hodgkin lymphoma, non-Hodgkin lymphoma, melanoma, thyroid cancer. So really starting to see a pervasive pattern here, as well as late venous thromboembolism, endocrine diseases. This is cardiovascular disease among AYA survivors of common cancers. In terms of socioeconomic disparities, we're seeing the same sort of gradient here. So the highest incidence of cardiovascular disease in this figure are among AYA survivors residing in the lowest neighborhood SES, and then those in the highest have the lowest incidence. So again, we're seeing a higher risk of late effects among AYAs residing in lower SES neighborhoods. And we've seen this among survivors of acute myeloid leukemia, non-Hodgkin lymphoma, melanoma, and thyroid cancer, as well as for really a variety of common cancers for venous thromboembolism, endocrine diseases, and cardiovascular disease. So very pervasive findings here. In terms of racial and ethnic disparities in late effects, the cardiovascular findings are here. You can see that non-Hispanic, African-American, or Blacks are much higher incidence of cardiovascular disease. And we see this in this group, as well as Hispanic and Asian Pacific Islanders. We see a number of late effects, not just cardiovascular disease, higher for those survivors of acute myeloid leukemia, thyroid, and breast cancer, as well as the conditions I mentioned before. So venous thromboembolism and endocrine diseases being high in non-Hispanic Blacks and Hispanics. And I've shared already the cardiovascular findings here. So really striking differences. I wouldn't say we don't do a lot of analyses looking at survival, but the ones that we've done, having one of these late effects is also associated with poor survival. So really important to intervene kind of at all of these different levels. And so my last sort of data slide before we get to what can we do with all this information, we looked at the medical expenditure panel survey. This is something I'd encourage. This is a national data set. It's a really great data set to utilize. So keep this in mind. This was a PhD student of mine who's now graduated, but she really focused on this data source and understanding medical utilization and costs. And this one was striking for late effects, that AYA cancer survivors with late effects were more likely in this national data set. You know, a lot of the work that I've been doing is in California, but nationally to have public insurance. And what does this mean? It means that for this population, they also have higher medical expenses, 568 per year, and more prescription medications, even after considering late effects. So definitely a population to target. And so why do we think we're seeing some of these findings? It could relate to more access to care difficulties, kind of fair or poor health, delays in receiving care, or unmet medical needs. And you can see here what these chronic conditions are often considered in these studies. Okay, so how do we reduce cancer disparities? So I've given you a whirlwind of data here. And this is what we're thinking about kind of in general, and how some of this work has really led to some policy changes, which is really, I think, an important area of research. So for cancer prevention and early diagnosis, really improving access to health insurance and improving health insurance literacy, show you some work there. Optimizing cancer treatment, so increasing clinical trial participation and receiving care at specialized cancer centers, And then in terms of survivorship, reducing racial and ethnic inequities and addressing late effects, which you saw is a big issue in this population. So improving access to health insurance, our findings overall may relate to reduced access to preventive care, early detection, timely treatment, or long-term surveillance. What we do know from other studies is that inadequate healthcare coverage can lead not just AYAs, probably most people, but particularly this population, to delay or forgo care. Coverage disruptions, which are common among poor and publicly insured, are associated with the lower receipt of prevention, screening, and treatment. So other studies are sort of pointing to understanding and contextualizing the findings I showed today. And then survivors are often faced with large medical bills and may have low workability or be unemployed. And so this then could lead to more foregoing of care due to cost. I did want to show some recent data, just to say we've come a long way with the Affordable Care Act, which is true, but we still have, we have more gains that we need to make. So in 2022, 43% of working age adults remain underinsured. So they might have some insurance, but they're underinsured. This means they have gaps in coverage or high out-of-pocket costs. And so who does this impact most? It impacts those who are poor, young, which is the population I'm talking about here, or living with a chronic health problem, which I think we could characterize as many of the cancer survivors I talked about here. And this has resulted in adults not getting the care when needed due to cost. So the lacking insurance or experiencing gaps have not been due, and this was some really important work here, by not being able to afford premium plans or cost sharing requirements. And this has resulted in a loss of Medicaid eligibility. So we're seeing still a pervasive issue, even post Affordable Care Act, in terms of health insurance. So we know that the Affordable Care Act has increased access to comprehensive affordable care. This is through expanding insurance options, including the marketplace, limiting out-of-pocket costs like copays and deductibles, and health insurance subsidies. But we have more work to do in this area. So we need policies to continue to improve the continuity and quality of health insurance options. So I think a really important area is in this policy area to continue to improve and reduce the financial barriers of health insurance. But with that, I think it's important to also improve health literacy. It can be really challenging to understand healthcare plans, and I think that's some of the challenge, not just in this population, but I think particularly here. So most health insurance policies include multiple layers of complexity, provider networks, tiered prescription coverage, prior authorization, cost sharing requirements. It's really, really complicated. And so young adults may not have much experience with this at all. And so improving literacy, I think, is another really important target. To really apply, kind of learn about insurance, because this can impact costs, out-of-pocket costs, really understanding and utilizing insurance to the maximum. So and then young adults also struggle with consumer protections like appeals that can really help manage the costs. So this kind of intervention and education is an important avenue of research. I've shared some of my colleagues' research here on this, but it would involve a number of stakeholders, not easy work to do, right? From insurers all the way to care partners, patients, and providers. But it really could help more successfully navigating the healthcare system and using insurance to the fullest and kind of maximize the costs that are covered and minimize out-of-pocket costs. In terms of increasing clinical trials participation, we want more people to participate in research. It's been a particular barrier in this age group, and we've tried to understand why that is. And sometimes it's just more time, right? More time to be involved in this, or not understanding what research is, or I don't want to be randomized. So there is some education around, the importance of this kind of work. And it's complex and there's long consent forms. So what we did here was a qualitative study to try to get recommendations for young cancer survivors from their perspective. How could we improve clinical trial enrollment, and then look at the provider perspective of what can we do, what do providers think we need to do to improve clinical trial enrollment. So these are some ideas. I won't get into the specifics here, but a really important area is to get more young people involved in clinical trials. And I did mention the importance of specialized cancer centers, just because of the quality of care that's provided, the improved outcomes that we've seen. And this in California has led to policy changes. So I think that is one potential avenue of this kind of work. So in 2023, data, including our statewide data in California, was used to support the California Cancer Care Equity Act. So this was pretty specific. It got more specific than we wanted. We'd like it a little bit broader, but it's a starting point, and it allows Medi-Cal, so our publicly insured managed care plan enrollees with cancer, to request a referral to a specialty cancer hospital. So they understood, the legislature understood that there were different outcomes, and we need to allow our more vulnerable population that opportunity to get there. And so we'll be evaluating this over time, but this is how this data can impact policy. And then we know not everybody can get to a specialized cancer center. Either it's far away, there's some other barrier. So how can we think of other ways to improve care through either knowledge dissemination, telemedicine, outreach clinics? So really disseminating out all the knowledge that occurs at centers like these out into the community center or community setting through partnerships, which is not an easy task by any means, but definitely an avenue for future work. Reducing racial and ethnic health inequities. So I think it's important here to interpret the associations really carefully. Race and ethnicity capture so many things. I mentioned some of those before, but it's racism, discrimination, culture, socioeconomic status, access to care, environmental exposure, genetics. It's so many things sort of wrapped into these broad measures. And really the relative importance of each of these factors to disease outcomes hasn't been adequately studied. So the important, I think, point here is to consider race and ethnicity as a social determinant one, but also with other measures of social determinants of health. If you can also have health insurance, if you can have measures, as many detailed measures as you can in your study, either with existing data, whatever is collected, or if you're able to collect as much information, trying to dig in and understand what's behind those associations is really key. But we need to keep documenting disparities. As imperfect as these measures are, we cannot stop documenting them because they are important constructs and we see such striking disparities. So it's important as a benchmark to continue to document what we're seeing and to continue to understand and design interventions to mitigate these disparities. So how can we do this? We have to report healthcare access and utilization by race and ethnicity, by socioeconomic status, health insurance as well, right? Increase awareness of racial and ethnic disparities in healthcare, in kind of everything I talked about today. Train health professionals about structural racism, social determinants of health, their impact on health, and then just continue research to identify the sources of racial and ethnic disparities. So as you saw, addressing late effects is a really a big issue in this population. And there are a lot of barriers to the surveillance and the need to address these. So I think the starting point is really educating young people with cancer that they need to care about their lifelong survivorship care and be on the lookout for these kind of late effects in the future. And it's just really the importance of continued care. We also know that the surveillance is not where we need it to be, where they're not all of the young people are really, even with insurance, we showed that data from Southern California, are not coming in for the routine care. They need to get the surveillance and management of the physical and psychosocial effects of their cancer, as well as a long-term surveillance for these unfortunate conditions that become very common in this population. And I think there's one other component here, which is health promotion and disease prevention. It's important for everyone, but it's particularly important for cancer survivors. And why is that? It's because unfortunately we found that cancer survivors and those of lower socioeconomic status or public health insurance have been found to be more likely to smoke, not exercise, have poor diet, or obesity. So that could compound some of the negative impacts of cancer in this population. So taking cancer as a teachable moment that can provide opportunities for lifestyle interventions is really key, I believe, in this population. And then I'm really trying to address this last one, which is really the lack of long-term data on outcomes and late effects in this population. We're continually evolving treatments and developing new treatments, which just means we know less and less about how those kind of current treatments are going to impact kind of in the long term our young cancer survivors. So just continually understanding that so that that survivors and providers both sort of are aware of what to look out for moving forward. So we are trying to do this work to inform survivorship care guidelines, and really the idea of using survivorship care plans to educate patients and family and facilitate communication between providers. So a survivorship care plan will really include all the treatment they've received, you know, the kind of care that they should get in the future. So giving them kind of a tool to work from kind of moving forward. We all do not want to remember unpleasant things in our life, including potentially the details of cancer therapy, but it's an important piece when thinking about kind of future risks and what to do moving forward. So I'm not going to repeat each one of these. This is just a summary here of some of the ways that I've been thinking about with others to reduce disparities. But I will kind of point out this quotation here. It's something I think about a lot. So the reason for collecting, analyzing, and disseminating information on disease is to control that disease. Collection and analysis should not be allowed to consume resource if action does not follow. So as an epidemiologist who has access to big data, I can report disparities sort of all day long, but I think it's important to think about what we do with that data. So hopefully this will give you some impetus to take some action in your own work, or just, you know, think about that in your future kind of research efforts. So I will stop there and take any questions.
I have microphones for anyone with a question.
You want a microphone?
A question and a comment. So I'm curious, one is, so on the survivorship care plan part, I think I was starting to mention last night, you know, we got grant funding from the CDC to actually look at how that impacts mortality. And I think with different models, it's going to be really important to actually look, because I think that it may not be helpful for everybody, but certainly for some it does.
Yeah.
So I have a question for you about, on the clinical side, I oftentimes see that primary care providers and patients, they don't know about long-term issues, even though we talk to them about it.
Yeah.
And we may say, go see primary care provider. You're at high risk for cardiovascular disease.
Yeah.
But they go see primary and they're like, oh, you're fine.
Yeah.
So I think also engaging, and so that doesn't help them go back to the provider.
No, they think they're fine. And
they
that's what
think
you
they're
want to
fine.
hear, right?
Yeah.
Yeah.
So I think also, you know, a piece of that of how do we incorporate primary care education and knowledge in addition to the patient education, I think is really important.
Yeah.
I'm curious if you guys have thought some about that.
No, I mean, I think it's a great idea. I mean, I haven't thought about that. I think that is an absolute next step, right? Because it feels like, how do we intervene at that level? And if we keep just pushing to other people, right, this kind of responsibility. I may have a question back though, like in terms of the survivorship care plan. I mean, are you finding anything, any association
We're
with?
still too early to
You're
tell
too
you.
early. You're too early. Yeah, I mean, I think.
Ask me next year.
But the promise of that, like having that to share seems so important, right? To at least from an education. Now, where it goes and if it gets passed on to those primary care providers, I think it's the dissemination of that and how they're used. Seems to me as an important kind of vehicle of, how we can help, this process. I would say the other sort of piece, and this is a challenge on our side, is just pushing this to the doctors, right? Like you have to do more. And that, I don't think that's the answer here. So how do we educate or make this easily available for people to look up, right? Not just make this is the oncologist survivorship care clinic or the primary care clinic. I think we have to think about how do we make this information more broadly available, or it becomes like one of the things they check at every, appointment. I don't know. It's a challenging one, but I hate to just move more onto. Yeah.
I think my one other is a comment on the clinical trial part. Part of Doug and I work as part of an I-SPY breast cancer team, a large national clinical trial in breast cancer. And if you get patients of all disparities on the trial, they actually have the same outcomes in terms of at least pathologic complete response, so their response to the treatment. But I think the one thing on the clinical trial piece is time toxicity is really important. These are young adults. And so some of our trials are so complicated and it's all these extra appointments that it's really overwhelming.
Yeah. And I do think that's been pointed out in some of the qualitative work that they don't want to go through, they don't want to come in more, they don't want to be in the hospital longer. So I think that is an important consideration. How do you simplify that or be more efficient in terms of the care? Yeah.
A question about the insurance topic. So you showed that outcomes are dependent on insurance, but one smallish bar was other public
Yeah.
that seemed to have roughly the same outcomes reference. So what is that? Who's doing
It's
that
our
well?
like our county funded in California. It tends to be our county funded public insurance. So just a little bit different, but you're right. I mean, it kind of goes both ways. We've seen no associations with that. It's a smaller group, or it's has the same, association as sort of our Medi-Cal program.
So I wonder if you had a look at the data, and maybe you suggested this about states that had Medicaid expansion versus those that did not. And of course, we all know there's a threat to the Medicaid expansion at the moment. And I'm just wondering if there are any tips for states that face a potential loss of the Medicaid expansion funds.
I mean, which is really scary, right? Because that just means a whole lot more uninsured population. So California was actually an early adopter of Medicaid expansion. So we've sort of been like watching along the way, like how that has impacted and changed things over time. And then during COVID, nobody lost their Medicaid for a while. And there was a big drop off a year or so ago of like a reevaluation of Medicaid. But I think I have not done those studies that have looked broadly at states, but there have been a number showing that this has really improved outcomes. So I think the data is there to show that this should not happen, that it has to continue, and that it's really that continuous kind of insurance. I think what our data, I think, has highlighted is that the public insurance can get a bad rap because it's a safety net and people are on and off, but it actually reflects a largely uninsured population or a population that has a lot of gaps in that insurance. So how do we get that to be more continuous? And it certainly would not be by, through that mechanism at all. So, yeah.
All right, that's the last question we have time for. Everybody say thank you one more time to Dr.
Thank you.